Hello everyone, my name is Elias-Leon Nolden and my PhD thesis is about the implication of personalized medicine in maxillofacial surgery. I'm a dentist as well as a medical student, and I'm from the Department of Oro-Maxillofacial Surgery and Stomatology, as well from the Department of Orobiology here at Semmelweis University. My supervisors are Mihai Vasilko and Laszlo Kölisch, and my statistician is Silvia Kirsteller. My vision is that customization leads to optimization for better patient results, and my mission is to provide better clinical decisions based on research. I have two ongoing specific goals. In my first specific goal, I'm comparing patient-specific implants with the stock system in patients with temporomandibular joint reconstruction. I'm using a systematic review and meta-analysis to achieve this goal. TMJ disorder are very common in our population. In fact, 11% of all children and almost every third adult are affected by it. And untreated, it results into failure of the joint, which will lead to unstoppable pain, problems with diet, mastication, speech, and social interaction. And we already know that in just 6 years, the necessary amount of TMJ replacements will increase by 60%, which will be around 900 operations in the year just in the USA. And we have two possibilities. Back in the old days, we like to use the stock system, which is a standard size system available in 3 different sizes, but this often comes with chronic pain. And on the other hand, there's a new kid in town, which is the fully customized patient-specific implant for the unique anatomy of our unique patients. And as stated in the current guideline, the total number of global cases is still insufficient to draw any stable conclusions for the PSI. That's why our aim is to investigate now if the custom or pre-manufactured implant leads to better patient results. And our clinical question is, so does TMJ replacement of custom implant or stock system result in better function and efficiency? We were interested in patients under TMJ replacement, and we're comparing the PSI with the stock system, and we're measuring the function by the maximal interincisal opening and the pain and diet measured by the visual analog scale. And the efficiency is measured by the operation time. And our hypothesis is that the PSI is superior than the stock system in terms of rehabilitation of the stomatognatic system. We conducted our search in 3 different databases on the 5th of November with the given search key. And after full text selection, we were left with 45 articles, including 35 one-arm studies and 10 two-arm studies. We have finished our analysis of the two-arm studies and are still investigating in the one-arm studies. That's why I show you my preliminary results regarding all the two-arm studies, and the first forest plot shows the maximal mouth opening. And it is of crucial importance for our patients that they can keep a mouth opening in regards to keep a good oral hygiene, have no interference with pain, speech, or diet. And we are measuring the mouth opening by the interincisal distance measured in millimeters. And as stated in the current guideline, the optimal mouth opening after TMJ replacement is between 30 and 40 millimeters. So each millimeter toward this direction will increase our patients' quality of life and makes the difference if they are restricted or, for example, can eat whatever they want. We have around 95 patients in the PSI group, and we are comparing it to the stock system with around 143 patients in the postoperative short-term follow-up between 0 and 3 months. We included 5 retrospective cohort studies and had a low heterogeneity, which can be explained through the diversity of the diagnosis of our patients included. In both systems, mouth opening could be increased. However, if we look at the mean difference of the mouth opening between PSI and stock system, we can see that the mouth opening in PSI could be more increased with 2.29 millimeters. This we consider as clinically relevant and also as not mathematically significant difference. However, if we're looking now at the long-term, postoperative long-term follow-up above 3 months with 92 patients included in the PSI and 129 patients included in the stock system, with also 5 different retrospective cohort studies and a low heterogeneity. Also here in both systems, mouth opening could be successfully increased, but now also here in the long-term follow-up, the mouth opening was larger with 5.6 millimeter in the PSI group if we look at the mean difference. This we also consider as clinically relevant, and this has also a mathematical significant difference. So this suggests that in short and long-term follow-up, the PSI is superior in terms of mouth opening than the stock system. If we are looking at our second outcome, the pain, here I'm also presenting you my preliminary results. We have pain is not only restricted to the joint itself, it affects the whole body and especially the head, and will decrease our patient's quality of life. We measured the pain with the visual analog scale, a scale from 0 to 10 centimeters, and as stated in the current guideline, also here a maximal pain reduction is necessary after each TMJ replacement to increase our patient's quality of life in long term. We have, in the short-term follow-up between 0 and 3 months, 76 patients in the PSI group and around 115 patients in the stock system with 3 different included retrospective cohort studies and a moderate heterogeneity which can be explained through the contradicting results, which you can see here. In both systems, pain could be decreased. However, looking at the mean difference, we see a change of 1 centimeter more decrease of pain favoring in the PSI system on the visual analog scale. But this is not clinically relevant and has also no clinical mathematical significant difference. Looking at the long-term follow-up above 3 months with 124 patients in the PSI group and 121 in the stock system with 5 different retrospective cohort studies and the low heterogeneity, but it has to be mentioned that we have here a very broad confidence interval. In both systems, again, pain could be successfully decreased. Looking at the mean difference of the pain change, we can see a slightly more decrease of pain in the PSI group, which has no clinical relevance and also not mathematical significant difference. This suggests that in regards of pain, choosing PSI or stock system doesn't matter. Our strength is that we have the most comprehensive study to date, and the first 2 are meta-analyses. And our biggest limitation is here that we only have retrospective cohort studies. Our conclusion is that customized TMJ implants enhance mouth opening but do not significantly change pain levels, and our implication for practice is that customized TMJ implants are suitable for patients with initially decreased mouth opening, while stock implants are more cost-effective for patients with normal mouth opening but greater pain. And our implication for research is that we need more precise follow-up times, and articles should offer more detailed insights into the cost associated with the TMJ replacements. And we are now in the phase of risk of bias assessment. And for my second specific goal, I'm comparing patient-specific implants and non-customized implants in patients with cranioplasty. And I'm using here a systematic review meta-analysis to achieve this goal. Cranioplasty protects our patients from CU procedures, can relieve headaches, and increases brain blood flow as well as brain energy. That's why it's considered as a standard procedure in neuro and maxillofacial surgery for brain protection and cosmetic aspects. However, it's associated with extremely high complication rates, 20 to 50% compared to other routine neurosurgeries, which are about 2 and 5%. And here also we have 2 possibilities. We can either choose the non-customized implants, which, as you can see on the left side of the picture, often show imprecise fitting and low aesthetic satisfactory. And the other would be the customized implant. And our aim is here also to investigate if the custom or pre-curved implant lead to better patient results. Our clinical question is then, does the cranioplasty with custom-made or pre-curved implant lead to better clinical performance and long-term success? Again, the patients will be under cranioplasty. We are comparing PSI with the non-customized implant, and the clinical performance is measured by the cranial index of symmetry as well as the time of the operation, the safety by the incidence of postoperative complications, and the aesthetic by the visual analog scale. And our hypothesis is here also that the PSI is superior than the non-customized implants in terms of rehabilitation of the craniofacial system. And the clinical implication will be a long-term implant survival, less secondary operations, and an increasing anesthesia exposure for our patients. We considered our topical as feasible and are working on the Prospero registration. And in summary, both of my projects are investigating of the implication of personalized medicine in maxillofacial surgery. And I would like to close my presentation with my favorite quote from Beethoven: "Don't only practice your art, but force your way into its secrets, for it and acknowledge can raise man into the divine." Thank you very much.
Congratulations, Elias. Just a quick question from your first topic. You have used change from baseline values, right?
Yeah.
Okay.
In both in short and long-term follow-up. Well.
Great. You mentioned that the limitation will be the, not the ideal follow-up times or the difference in the follow-up times. What do you think, like which one of these short or long-term, or what would be the ideal time point that you wanted to see later that you couldn't find? That would give the best answer whether it was performed better or not?
Thank you for your question. My point was more that a short and a long-term follow-up, I think, is necessary to see how the reconstructed joint develops. My point was more that the articles sometimes didn't give exact follow-up points. They gave mean or even median. So I think it would be just better if we wouldn't have summed up follow-up times and more the exact ones.
Thank you.
Thank you.
Thank you for your presentation. Do you know anything about the price differences, the two systems, the stock system and the PSI?
Thank you for your question. Well, this question is quite difficult to answer because if we're looking in price difference, we also have to take into concern that the price is different between the different countries, the different regions, as well as the price for those implants changes a lot in the last 10 years, as for example, the also customized implants are nowadays easier to produce than maybe 10 or 5 years ago. So, but to give you a number, we can say that the stock system is about 8,000 to 10,000 euros, while the PSI or 3D printed implant is above that, starting from 10,000 euros. Thank you.
I have a question for the second topic. Which type of material would you investigate?
We are interested probably in all of the materials they use. Mostly it's titanium. Some others we saw is like polyether. But those two ones are the most common ones which we found out in our preliminary search.
Okay, thank you.
Thank you.
Congratulations, your excellent presentation. Maybe it slipped my attention, but I'm assuming stock system is something you can choose out of a catalog, kind of. And if you use PSI, then it's something that has to be, it takes time to make. So what's the actual time difference between the two? Like, is it really a lot longer to make the PSI, or is it also can be as effective as the stock system?
In terms of time, there's definitely a difference. As you already said, for the PSI, we need medical imaging first. We need to convert these medical imagings into a program which then digitally designs the implant. And this needs to go back to the company which produces the implant then, and this has to come back to us. So we can see their follow times for like almost months or something. So it definitely takes longer.
Thank you.
Thank you.
Really nice presentation. Congratulations. I'm interested in how available are patient-based implantation, cranial implantation, maybe in Europe or maybe in Hungary. Do you know anything about it?
It's definitely getting more and more available also in small hospitals. Of course, there's still a heterogeneity in concern, for example, for the TMJ replacement. I know that in the Eastern Europe, the biggest hospital is the Slovakia, which do a lot with PSI, but also I think here in Hungary we definitely use it. But I would say nowadays it's more or less available to get for almost every good financial hospital.
Thank you very much.
Thank you.
Thank you for your presentation. I have one question, and sorry for that in advance. In the mouth opening with short term, I've noticed that there was an outlier. I didn't have the chance to memorize the author, but it started with an M. Could you please give me a reason for that outlier?
Yes, if I remember correctly, this was Machaona, which you are referring to. So they included 4 patients for the PSI, and 3 out of 4 patients had congenital jaw anomalies. So we are definitely thinking about doing subgrouping based on diagnosis. And if subgrouping is in this for congenital jaw anomalies not possible, then we are considering doing a leave-out analysis.
Thank you so much.
Thank you.